Welcome, everyone, to another of our POCUS Power Hours. Tonight, we're going to talk about the use of point-of-care ultrasound in EMS. It's actually a great subject. I'm John Martin. I'm the Chief Medical Officer of Butterfly, and I'm joined by a distinguished group of colleagues here who will introduce themselves shortly. But maybe I'll start with maybe just a brief of why we think this is so important, and maybe a personal note of why I think it's so important. And I personally drug Peter into the EMS team in my hometown here in Annapolis, Maryland. And when meeting with the chief, he said, "Why are you so passionate about this?" And I said, "Well, when I go down in this town, it's you guys that are going to come see me, and I want you to have the skills so that you can take care of me appropriately." And he looked at me and he goes, "You mean that?" And I said, "Yes." And said he was bought in. And I think what you're going to hear tonight are reasons why, A, it's been adopted by some across the country and some great data as to why it's been adopted. Two, or B, what the hesitation has been and maybe some key steps on how we can accelerate adoption. And then maybe look for some questions from you on what may be the things that are on your mind as how you can accelerate it in your town. I think the data is overwhelming that it's the right thing to do, and I look forward to hearing my colleagues tonight express the reasons why and convince you, and maybe all of us together can make it a standard part of the equipment on every bus across the country. So I welcome all of you tonight, and feel free to use the chat or put in questions in the question era and Q&A, and we will answer them as we go through. Don't hesitate to ask anywhere along the line. We would like this to be a dialogue, not a lecture, and we look forward to your input. Peter, do you want to take it from here?
Sure. Yeah, thrilled that you're all joining us and really hope for your input and participation. Really look forward to a dialogue with what you're interested in, how we can support your journey in EMS. I'm going to introduce my colleague briefly, Dr. Devinder Ramsingh, who is an anesthesiologist and really outstanding in research and congestive heart failure. So we're going to go there in this conversation. So Devinder, um, take it away and we'll start up with our guests.
Sounds great, Peter. And yeah, no, just echo John, thanks for that kickoff. Super exciting topic. I know, Peter, you and I were just talking about this last week about the amount of intake Butterfly has seen in the EMS world as an emerging area of people wanting to learn about POCUS, embrace POCUS. I mean, it's significantly higher than any, the last couple of years that, I've been monitoring it with you. And so super excited to engage kind of what's happened out there in the world about with EMS providers and really taking it on, because it really feels like we're finally getting to that inflection point where people are wanting to get it and adopt it and use it, right? So excited to jump into that conversation. And, maybe Peter, if we just hand it off to the panelists to do a quick intro and kind of just, like we always start off about maybe that first, what got you into the space about POCUS, especially under EMS. Would love to get your initial thoughts there, and then we'll just dive in. Encourage everyone to please answer, to offer questions. We'll be monitoring that and look forward to a great discussion.
So Tyler, you're on my upper left. So clockwise, take it away.
So I get to
Tyler
go first.
Christofoli.
Yeah, thanks, Peter. So my name's Tyler Christofoli. I am a flight paramedic for Lifelink 3 out of Minneapolis, and then the co-founder of FoamFrat. So it's like an online education service. And we go around, we teach ultrasound as well. But the thing that really kicked off ultrasound, when I first started flying at Lifelink 3, they had this ultrasound tool, and I thought it was really cool. And I remember looking at it and being like, this is super cool that you can actually look inside and see what's going on with the patient instead of trying to guess. Because everything in learning in EMS is like, okay, well, I think I see tracheal deviation. I don't really know what muffled heart tones really sound like. And now you could look in and actually see it. And then I remember hearing that there was like all this like trepidation about it. And I was like, I don't understand why medical directors are against looking in and actually seeing what's going on with the patient. And so that began my fascination with it. Been using it now for a long time, and I'm excited to talk about how I think the right way to implement this is. There's a lot of places that get started, and there's kind of like a false start, and then they all end up sitting in a closet somewhere or on a supervisor truck. So I'm excited to get in the discussion. Thanks for the invite.
Thanks, Tyler. I guess, Ben, you're over in the clockwise. So hi, Ben, and thanks for joining
Absolutely.
us.
Hi, guys. Thank you very much for having me. My name is Ben. I'm sending my warmest greetings from Germany. Usually I'm based in Vienna, Austria. I'm a senior physician for Vienna EMS, mostly working pre-hospitally. We have a pretty large pre-hospital based system here in Austria where we have lots of physician-based cars. And I do also fly as a HAMS physician in the Austrian Alps on 2 helicopters. And I was standing like, I would say 6 years ago, I was still standing like a rabbit in front of a snake when it comes to ultrasound, because I always thought to myself, you need to have some deeper understandings and 3D thinking capabilities of understanding what's going on. Unless I figured out that it's just you have to write up a quadrant. There's going to be the liver, there's going to be the kidney, and that big black space in between supposed to be free fluid. And then here's the next view, the next view, and the next view. And now when I'm standing at the booth and explaining people some cardiac views, I still feel like a little cardiologist, and I'm still very proud that I managed to dig my way through and to influence now the younger generations and also the paramedics of becoming proficient in ultrasound. So I totally agree and can identify with what Tyler just said. And I'm glad that we're living in 2025 and get the paramedics on board as well.
Awesome.
Was that good?
Francis, for all of you who are listening, Francis actually has the far end of a table in the same room. Anyways, so Francis, thanks for joining. This is Francis Russell from Indiana University. So please introduce yourself and talk ultrasound in pre-hospital.
Yeah, sure. Thank you for having me. So my name is Francis Russell. So I'm a professor of emergency medicine at Indiana University, and I'm one of the ultrasound faculty there. And I started studying ultrasound, so lung ultrasound, cardiac ultrasound in patients with undifferentiated dyspnea in the emergency department back when I was an ultrasound fellow over a decade ago. And so I've been using it a ton to train residents, faculty within the emergency department. But a lot of literature has come out over the recent years, specifically for patients with heart failure, that if we can make a diagnosis earlier, we can start treatment earlier, then we can really improve outcomes for these patients. So things like decreasing mortality, decreasing hospital length of stay, recidivism. And so about 5 years ago, I was fortunate enough to have a really great team. One of my colleagues was a medical director for an EMS agency. It was a smaller agency. They were really excited about using ultrasound. And so we started implementing using butterflies, using lung ultrasound to diagnose heart failure earlier as a way to start treatment earlier. So I'm just excited to be here and talk about pre-hospital ultrasound with you guys.
And Francis, that paper that came out from that group was really it's the first paper that was not only doing the fact that it's achievable and doable, but that you were measuring outcomes. And I'd say a couple of things I'd love to have you talk a little bit, but one thing that was really striking to me is that when I teach why use ultrasound for lung versus not, I talk about sensitivity of the exam, and my talk as the sensitivity is a coin toss, right? It's you're guessing. And what's fascinating about what you're doing with the pre-hospital providers, what they had, 30 minutes of the training was minimal, and they were outstanding at picking up the difference between dry lung and wet lung, or at least B lines versus other. And the sensitivity of paramedics without the ultrasound was 23%, which translates to 3/4 of the time they were wrong in their pre-hospital assessment, which to me is an astounding number, that you have medics in good faith trying to do the right thing who are going to choose an intervention that may, in theory, is at least harmful. So I'd love to. That was a striking number, not only in terms of how good they could be for a little training, but just even the numbers of without an ultrasound, how difficult it was to assess why a patient would have undifferentiated dyspnea.
Yeah, so before I even did the study, I did a prelim study just to see how good are paramedics at being able to diagnose patients with acute heart failure, not even implementing ultrasound. And we found that specificity was really high in the upper 90s, but sensitivity was only 14% in that original study. And that was pretty congruent with the literature that was already out there. And so in talking with paramedics, it seemed like they really wanted to be positive that this patient had heart failure before they started treatment. And in where I practice in Indiana, the only pre-hospital treatment they really had was nitroglycerin and CPAP for patients. And then when we studied it, and yeah, it was very limited training. It was an hour long, 30 minutes of didactics on like what we're looking for, how to do it. And then we did 30 minutes of hands-on scanning. And then we did a short OSCE where we evaluated them individually. And then importantly, which I think is missing from a lot of studies on this, is we did ride-alongs with the paramedics so they knew how to integrate it clinically and to show like, this is when I would use it and this is how I would interpret it. And so I think that that helped. And so we were able to improve sensitivity from 20% to 70% without sacrificing specificity. And it improved treatment and time to treatment.
Can I cut in real quick on this? Because I think this is really interesting. So part of the education we do is we do live classes Monday through Friday. So we have tons of paramedics and EMTs, all levels that come in. And so I do this talk on balloon pumps, and a lot of the people coming in have no idea at all about ultrasound, right? They've never seen a parasternal long, parasternal short. And so I tell them, all right, I want you guys to imagine you're going into the Golden Gates Hospital right now. And this guy, Norman, comes in and he's feeling really weak. And can you guys see my screen okay on there? So you see Norman walking in. Yeah, I mean, this is before I really studied art and animation. So, excuse the crude graphics here. But I'm like, this guy comes in and he's got chest pain. He's not feeling good. He's feeling lightheaded. And I'm like, his blood pressure is 70/44, heart rate of 123. And I'm like, what do you guys think is like the first thing we should do here? And, we got to get a 12 lead. We got to get an IV and we got to give him some fluid. I'm like, all right, let's get a 12 lead. It prints out awkwardly out of the side of the Zoll X series. And so we look at the 12 lead and this dude's having an MI, right? We can see he's having an MI. We got to get him to the cath lab. But I ask, how many of you right now would give this guy 250, 500 mLs of fluid? And everybody's like, oh, yeah, we got to get some fluid on board. Maybe think about pressors. And so I get a little bit of buy-in here. I get them to say that, yeah, I would give this guy some fluid. And I'm like, all right, I want to show you something. I'm like, the doc throws his butterfly probe on Norman's chest real quick, and he sees this. I was like, let's blow this up. And I just want you guys to answer one question. I'm going to show you normal, and then I'm going to show you Norman. And I want you to tell me on Norman, if I give this ventricle more fluid, will it eject more fluid? And even without knowing anything about ultrasound, everyone goes, no. I go, do you still want to give Norman fluid? Absolutely not. I said, you've never seen ultrasound before, but just putting this into context, you can look at it and say, this is engorged. This is big. This is not adequate. This is not something that is going to be on the upswing of the Frank Starling curve. And so it's just really interesting to see that, because just within looking at these two images, they go, that's not a heart that would get any bang out of the buck for giving more fluid. And so to Dr. Russell's point, it's totally within the scope. And the scope of knowledge that paramedics can look at this. They can go, okay, probe marker goes here. Dr. Weimersheimer has an excellent algorithm on how to get there. I'm actually about to put out a podcast that we did. It's not hard. You can get a decent view. You can answer that clinical question. And you just then made that decision that this guy doesn't need fluid. Maybe we start some Levofit, we start some inopressors or whatever. But I think that that's super interesting to see how fast EMTs, first responders, my wife, people who know nothing about EMS, the heart, they're not cardiologists. Dr. Towle made the comment, do you feel like a cardiologist? And when you're like, oh, well, look at the E-point septal separation on this thing and the fractional shortening. And then you're like, you know what? I don't need to say all that. I can look at this and answer a quick clinical question without all that background measuring and color Doppler. Those things are cool, right? And granted, I think that they definitely have a space. But when you're in the back of an ambulance doing an intercept and you're trying to figure out what's the best thing to do for this guy, it's those simple clinical questions. And what I find
Absolutely.
is a lot of people are hesitant to pull out the probe because they're like, the probe isn't actually doing anything therapeutic for the patient, right? I feel like I got to be doing other stuff. I got to start an IV. I got to get fluid. Maybe, I'll take a look on the way to the hospital. And that's the wrong way to approach it. You have to say, when I have a clinical question and I want more evidence, that Bayesian thinking is as new information comes, I change my decision. And I think that's where the FAST exam, whatever, that's cool. Everybody knows the name EFAST, but making these heart-lung decisions, do I control the rate or do I not control the rate? Do I give fluid or do I not give the fluid? I think that's where it really shines. So I hate to cut in, but it fit perfectly in with what you were saying, Dr. Russell.
Yeah, no, I think that's great. And I'd love to hear more about your experience with cardiac ultrasound. I started with lung because lung is probably the easiest ultrasound to learn and to use. But cardiac, I feel like, is, for me, one of the most impactful ultrasounds, but it's also the hardest to do. And so I have yet to kind of jump into that with paramedics or EMTs because of my fear for how difficult it can be.
So when you are teaching them this, and this is maybe something for another discussion, but you're looking at B lines, for example, right? So you see some B lines. How are you differentiating between infiltrates from or B lines from cardiogenic shock versus like other causes of B lines?
Yeah, that's a good question. So typically with heart failure, the pleural line is going to be very thin. And in patients with ARDS, COVID, or even pneumonia, the pleural line can get somewhat thickened and irregular. And so I will typically have them look for that, but it's not always going to be perfect. And we had one patient out of, I have about 900 patients. One patient that had an ultrasound that had B lines that were bilateral, and they had multifocal pneumonia. They ended up getting furosemide. The patient did fine, but that's going to happen. And to me, one out of it was 109 ultrasounds that were done out of 900 patients that were transported with dyspnea. That still is way better care for those 109 patients that had ultrasound than that one patient who got a treatment that probably didn't help them. It didn't harm them. So it's kind of a risk benefit. And so really I'm just teaching, are there B lines there? Yes or no. And I tried to make the protocol as simple as possible so it could be done easily in a fairly short time, because our transport times are about 10 minutes median time.
And there's always the clinically correlate, right? If somebody's got a fever and you got the coughing up stuff and they've been sick, it's probably not cardiac in origin, right? It's like the Berlin criteria. You rule out that it's not due to the cardiac cause. But somebody's got ST elevation, chest pain. It's the CHF patient that wakes up in the middle of the night with shortness of breath. That one, you're like, okay, that probably is. And so what decisions is that helping them make when they say, I think this is cardiogenic shock? Is it a pause on fluid? What does that look like?
I think, Tyler, go ahead, Peter.
No, I was good. Okay. Go.
Well, I was going to say, this conversation, it's so many different levels that you can jump at, right? In terms of, the world can be so vast when it comes to implementing POCUS in this care setting. But that approach, for instance, that you took about taking lung ultrasound and adopting that, because is it, a good gateway to entry? We kind of quickly talked about that prior to going officially online. Ben, how was in your care setting? What is that modality? Has it been lung ultrasound that's been the first approach for paramedics, or is it procedural, or kind of where do you see that first step? And then I know it's great to see we got some questions coming into the bank here. We'll get to those here in a second, but would love to get your thoughts here and kind of like the approach of where to go.
So Actually, I was just thinking to myself, I absolutely identify with the approach that you took now in this answer, because you can always discuss everything to a certain degree, right? You can start discussing an intubation process at the beginning level, and you can, on the other hand, do the big Scott Weingart bougie talk with 10,000 different techniques on inserting a bougie, especially on the 180 kilogram patient, and you can always escalate the thing. The easier thing, and that's what just struck me, is what Tyler just said about the question that was distinguishing the POCUS or POCUS from the holistic approaches. You have so many questions when you assess a patient, and the paramedic has these questions even without ultrasound. So, for example, in our e-learning that we did, I took my 8-year-old daughter and I tried to give the learners an example about what POCUS is all about. So I took my 8-year-old daughter, I took her to the studio, we put her in front of an ultrasound machine, and we showed her 2 pictures of a bladder, an empty bladder and a full bladder. And I just asked her, what is the consequence of a full bladder? And she said, yeah, well, the problem will have to pee soon. And that's absolutely right. So here's your patient, saw a picture with the empty bladder and the full bladder. So go find out whether she will have to go to see a restroom soon. And she had literally five minutes of training. She's an 8-year-old undergrader, and she perfectly figured it out. And that's like the whole point of it, You can always discuss, okay, what shall we, and even especially doctors like to do that. Yeah, let's think about what parts of POCUS can be suitable for paramedics. I ask myself from time to time where this audacity is coming from to think that just because we went 6 years into our books, that we're predestinated to perform a skill better than a paramedic. Because study shows, even, for example, if you take an airline cockpit, you have the co-pilot and you have the pilot, and the captain. And the captain does the flight from Vienna to Zurich, and the co-pilot from Zurich to Vienna. And it's absolutely clear that if we're then are going to approaching Madeira with 30 knots on tailwind and a short runway, that the captain's going to land because of his experience. But nevertheless, I think doctor and paramedic should be having exactly the same skill. And if they if they're going to have a certain degree of training and of routine, they're going to become better. So I love the approach to start their education exactly the same way as I would with a doctor. And that was my question that I wanted to ask Francis. What was your feeling when you first did a cardiac exam? Every one of us had the probe in his hand for the first time and asked himself, holy crap, how should I ever perform this apical 4-chamber view? And then he did it and did it and did it and did it and did it. And suddenly you had this first golden moment where you thought to myself, wow, am I just seeing the 4-chamber view? Did I just do that? And I think it's no difference whether you're a doctor or a paramedic. You just have to keep on training. You have to do some decent education. And whether you're a full bird cardiologist or an advanced paramedic doesn't make a difference. If you have somebody who explains the things easy to you, like just Tyler did to his EMTs, why shouldn't they be capable of doing it and also grow into it? We started with our paramedics and they had absolutely no idea how to start an EFAS, and then they get absolutely eager to learn it, and they dug into it, and they have YouTube and 1,000 e-learnings and everything, and they pick their mentor, and three months later they're overwhelming you with questions you would have never thought that they would rise. So it's getting easier and easier, and I think it's really time to overcome this thinking of, because we're doctors and we went to med schools, we're the better practitioners in ultrasound. It's just a skill.
unfortunately, just because someone's a doctor doesn't mean that they know how to use ultrasound either, right? And so
Yeah,
there's a lot of
that's
times where we fly into these small facilities, rural facilities.
fully agree.
They're working a cardiac arrest, and they have an ultrasound machine right next to the bed collecting dust because nobody knows how to use it, right? And so
Yeah,
being able to pull it out and be like, yeah, I got a clinical question I want to
yeah,
answer. And I saw over here in the question, Brian Ellenbach, I think he said, or I think that's how you pronounce his last name. He said personnel is always an issue, and especially with regard to access to physician-mediated education. So like the initial education, how might one build an education system with multiple regions but only one medical director? And so
yeah.
leveraging simulation. And I think this is interesting because where I fly at Lifelink 3 out of Minneapolis, this was one of our first issues. We used to have the Hennepin residents would look at all of our ultrasounds, right? And then it was kind of hit and miss, and then you'd have residents finish, and then there'd be new residents, and there was just kind of it was a toss bag whether or not they were going to see your scan. And so Lifelink 3 implemented this thing where we have subject matter experts at each base.
Mhm.
Every single scan is reviewed by them, and then it's also peer reviewed. And one of the things that I think is really interesting is how do you QA ultrasound, right? Is it, oh, they did a really good job of getting the image, or they you know what, they didn't include the liver tip. And what we found, like those things are important. You do have to know how to get those. But the thing that we found was the most important question is in this workflow. So I'm just going to show my screen real quick. So let's say I go out and I get an ultrasound on a patient, right? And it's based on a clinical question. Maybe my question is this rate compensatory or is this rate the issue, right? And so I get my ultrasound, and then I go and I'm going to upload it to my QA system, and it's associated with the PCR report. And in this little survey where I upload the thing, it says, could you answer your clinical question utilizing the ultrasound images obtained? This is one of the most important questions because we all know there's some patients you just can't get a good view on, right? And so you're trying and you can't. And if you say, yep, I answered that clinical question, and then you look at the view and you're like, I don't even know what I'm looking at here. That shows a fundamental mismatch there, right? They're answering questions without actually knowing what they're seeing. And so then let's say I'm the POCUS reviewer for that base. I review it and I look at it and I say, could they answer the clinical question utilizing that ultrasound image obtained? And what we're looking for is not that every single ultrasound is perfect, but it's this competency ratio. It's looking at, do the yeses match and do the nos match? And if they do, then we know that on that patient with a lot of adipose tissue, that 400-pound Wisconsin unit patient that we couldn't get a good view on, that on that patient we couldn't answer that clinical question, and that's okay, right? You don't sit there and you move on. We have other things we can look. It's a tool, but this I think is I don't want to say the golden ticket, but I think this is where it's at because there's a lot of times people are like, oh, I don't want to upload it because I didn't get a good view. That's fine. Upload it. But just say I couldn't answer the clinical question because that shows you know what it's supposed to look like. You just couldn't get it. And so to go along with what that question said, I think you do need to have peers reviewing it, right? Because they may have a really good pericardial tamponade and they're like, oh my God, look at this right ventricular collapse during diastole. But if they're the only ones who see it, then they're the only ones who learn from it. So you have to have some sort of system, which is why, shout out to Butterfly, but the system that Butterfly uses for the QA, having that implemented in the software with the program is huge. Like if you're looking
Mhm.
at buying a random probe and you're like, oh, we'll just upload it to the Google Cloud. It's like, okay, that's not a system. You have to have a system where you can actually provide that QA. And so I'm curious with you guys, like seeing EMS, do you guys see any systems where maybe ultrasound fellows review ultrasounds from the field? Like, what does that look like in your experience?
Yeah, I think that's a great question. I do think this gets back to implementing ultrasound in the pre-hospital setting. Personnel is always going to be an issue. We have the same issue in the emergency department. And so I think starting out small So I started with just 26 paramedics, and I started with one modality, and that's what I taught them. I was on a webinar about a year ago with two other women who were implementing pre-hospital ultrasound, and one of them just like taught them every modality, gave them like a bunch of probes and said like, have fun, good luck. And no one used it because they really didn't have the oversight there and in process. And I have to say, like Butterfly, having like a handheld ultrasound machine that pre-hospital settings can afford, as well as having the cloud system is imperative to be able to track the ultrasounds that are being done, be able to follow up the patients, and then being able to give effective feedback so that they know, oh, hey, you missed these B lines, or hey, your imaging, you were zooming in and that's why you couldn't see anything. And so being able to give feedback in relatively real time is going to be way more effective for learning it. And as Ben kind of mentioned earlier, you just have to use it to get good at it. No one's going to be great at ultrasound when you're first using it. And you get better the more you use it. And what I found is that when paramedics use it and they make a diagnosis and they stop giving albuterol and fluids and they start diuresing, like they get excited about how they're positively impacting that patient and the care for that patient. And so I think that that's huge as well.
I think, Peter, one of
Absolutely.
that I think I would throw out there is that the 3 letters or 2 letters after your name does not necessarily define your skill set or your ability. I mean, you may have a different education, but at the end of the day, what's easier to do, a lung ultrasound or put an IV in a 400-pound person who's in renal failure and had multiple dialysis accesses? We have no problem asking a paramedic to do that. Oh my goodness, I'll take the lung ultrasound all day long. Yet we don't think twice about asking them to do that. So I think it's all about fundamentally what we train them to do. And I also think the training systems that we put in place aren't that different for whether you're an EMT or an MD. We need to do the same QA process for physicians and learning. And I think what we've seen in the world of ultrasound in medicine is it's now penetrated the residency programs and now medical schools. And I think when this finally gets to where it needs to be, it's going to penetrate EMT training as a fundamental skill set that they learn, like all the other fundamental skills they learn, because it's so critical to deliver the best care. And I think what we got to do is learn from what we've done already, and then the skill sets that you guys are training your people, for people that are out there already, need to encourage it and show the data so much that it continues to move to the left of the education platform, so it becomes a fundamental skill set that everybody picking up somebody and transporting them know how to do, because it just transforms the way you're cared for. And I can tell you, after my first experience of intubating somebody in a helicopter and trying to listen for lung sounds, good luck, because you can't hear anything in that helicopter. It was just a guess. But looking would make all the difference in the world.
And when we
You
go out
know,
Absolutely.
to,
I think one of the
oh, go ahead.
things, all of us here are involved in point of care ultrasound, and all of us, I think, at a personal level, understand that this has started from learning 1 or 2 basic things. And Francis, to your description of that aha moment, right? When we're teaching, when we're educating learners, and this is independent of title or specialty, there is the learning by someone that when they use it, they actually can recognize something that can make a difference in someone's life. That's why point of care ultrasound has made it to the clinical space. And so, to John's point, as like, where else would you want to be? You have a environment which is very chaotic, it's noisy, it's not optimal, and you're trying to make an assessment and do an intervention on a patient where the decision you're making in the field will translate toward their success and survival or benefit going forward when they get to definitive care. And so, learning how to do a lung, that's fantastic. Adding a cardiac view onto the lung. So again, are these B lines local? Are they diffuse? That's pretty basic. But if they're diffuse, now I'm looking at a heart that is squeezing rapidly, or is it squeezing kind of poorly? And just harnessing just bits of information to get those aha moments over and over again and expand that repertoire where different questions become attainable is really a fundamental way that we learned, where we teach people, and towards pre-hospital medicine or paramedicine, that's success is going to be built on those stepping stones of learning, and it's independent of title, to the point.
You know, Peter, a question that comes to mind hearing this discussion is something that I kind of would love the panel list to kind of weigh in on. When you take the MD comparison, right, of physicians, you have societies that are nationally organized that can come up with hey, this is our strategy for education, these are our guidelines, recommendations for education, and then there's kind of more of a national front on supporting the routes for training and credentialing and things like that. But I'd love to hear a little bit more about kind of where the environment is in that pre-hospital space, right? Both US and abroad in terms of, because my understanding, it is so regionally different, right? And then it even seems to be more the need to find regional champions to be able to kind of to be able to get to the points that Francis you talked about hey, being focused on a particular topic and then involving QA. But it seems like it has to kind of stimulate from that like regional local level even much more than it does on the physician side. I mean, that's my sort of as an outside observer. How does the panelists, do you feel that, or any comments there about, how we build structure in the space around training?
I would say, like, I mean, and I don't know, this may be the wrong thing to say, but I feel like even the physicians that use it are regionalized, like maybe there's a clear pathway to people who want to be good at it. But the people that actually use it is a completely different thing, And so if somebody wants to be good at ultrasound, they can go get more education. They can do a fellowship, or
Absolutely.
they can start taking online classes. That's no different than paramedicine. I mean, or EMS, I should say. Not, if a service wants to be, I don't say progressive because that word gets thrown around a lot, but if they want to be progressive and they want to give their team the tools and they trust them with the small stuff, now they can start trusting them with other diagnostic measures. And there was this era, and you guys probably know what I'm talking about, but because these devices are getting very reasonably priced, people were going, oh, you know what? My service doesn't want to buy this for the company. I'll buy my own. And so they would buy their own, and they would have all these images living on their iPhone somewhere. And it was because they want to be able to look inside the body and see what's going on.
Mm.
They wanted to be on that leading edge, but their service was, they say in EMS, you can cross a state line and go back 20 years in EMS. So it just is so dependent on the area that you're at. And so I think when it comes to, the training, obviously that has to come down to, I say in one of my talks I do on implementing POCUS, I call it the path to POCUS. It's like the Emerald Road or the Golden Brick Road to Emerald City. And I'm like, you have to have an engaged medical director. You have to have a good QA, QI system, and you have to have a good simulation program. Like those three
Absolutely.
things seem to be the most common. Like that's the recipe. If you have those three, then I get into this, I made up this thing called the POCUS taxonomy. It's kind of like Bloom's taxonomy. I just flipped it over where like you just start off learning views, right? Okay, this is lung, peristernal, and then you get into understanding normal versus abnormal. And then you start learning how it applies to your physical assessment. And that's where SIM breaks out. You get in there and you break it out in the middle of SIM. And it's not an ultrasound training session. It's just a simulation, because if you isolate ultrasound in its own thing, people don't know when to break it out on a real call. And then up here is like the clinical decision making, QA, QI, teaching peers. But it's like those are the things, and that's the order I think works. This isn't study, this is no paper, this is me on Microsoft Paint making something up. But I think that's the way that it should go. That seems to be the way that works with my mind. And so when people want to get involved with this, they have to attend things like these. They got to pick our brains, shoot any of us emails. We can tell you what that recipe is. You don't have to recreate the wheel. It's already
No.
there. You just got to reach out for it. I see you shaking your
Absolutely.
head.
And there is already lots of experience out there. It's like our training program is similar. You will start with an e-learning, then you will go to the POCUS simulator, then you will have your first hands-on training on the patient, then you will have a 2-day simulation training, then you will have to collect your cases, you do final teaching, and then you will get certified. But I think the magic word that you just said is trust, because you always grow with your challenges. Like one of the most impressive things when it comes to the QA system, we're in the lucky situation that we are really just implementing ultrasound. We've been starting implementing ultrasound. I finally got my to convince my superiors and our compliance officers to trust the evil bad cloud where the data is being stored. And of course, we also got to the point where we asked ourselves, okay, how are we going to set up these Q&A systems? And one thing stuck, because we were reaching out to East Anglian Air Ambulance and also to London HAMS. We were having great contacts. And one of the things that they said to me, and the coolest thing is if you implement paramedics reviewing the studies of the doctors. And that's exactly the same approach. Like, for example, our field supervisor, who is an advanced paramedic, is debriefing the whole team. And this, at the beginning, everyone was looking what's going on, and now this became totally normal. And I think if we trust the paramedics, and as you just said, all the information is there. Go feed ChatGPT with a question around ultrasound, around B-lines, or type it, please explain me once again, what is that parasternal lung axis view? But please explain it to me as I'm a 10-year-old. You will be amazed about the answers that's coming out. So we have all the tools. We have wonderful training programs. We have YouTube. We have Butterfly Academies. We have Scan Labs. We have ChatGPT. We have great colleagues. So we're not back in the days where we need to have the big professor and ask his permission to learn. And I've seen nurses and paramedics in other skill sets. For example, if you see that it's the same discussion with the ECG. When I was trained as a paramedic almost 25 years ago, it was absolutely unthinkable that a paramedic in Austria would analyze an ECG. No, this is doctor's thing, and you have to be a doctor to do that. And nowadays, as a senior physician, I'm receiving calls during my shifts from our paramedics with ECG questions that are starting my sweat going, because they're better than me interpreting these things, So I think we will. It just all narrows down to trusting the people, to standardize process. For example, you can also, why would I pick, if I take such a wonderful thing like the RUSH protocol in undifferentiated shock, why should I only pick a couple of examinations or cuts out of it and give it to paramedic instead of doing the whole process? If I put a nice standard behind it, and I show the targets that they will have to learn, and I ensure that the simulation and the training and everything is there for them, and all the information and the training program is there for them, they will be as good as many doctors out there, And it's just what you said, Tyler. We all know fantastic anesthetists, and we all know shitty anesthetists who want also be able to bring a tube in. How many times have you been sitting next to an anesthetist thinking to
I
yourself,
have no
Jesus
idea what
Christ.
you're talking about, Ben. I interject that that's not a possibility. Yeah.
It's all about training.
Notice
It's
that Ben
all
didn't
about
say
skill.
emergency physicians, Devinder. There's a question from Barry about, and I think Francis actually fits into what you were doing with your medics, but it's when POCUS is used by ground ALS. How does that affect either treatment or decisions about destination treatment? And certainly heart failure was one, and the idea of even recognizing EFAST, for instance, which has a positive fast, is that going to just transport? And so, if you want to elaborate a bit on that, and also curious what your next study is going from that concept.
Yeah, so for us in particular, looking at heart failure or not heart failure was really the question. And then they were just instructed to follow their treatment pathways that were already in place. So if they found B-lines, then they followed their heart failure pathway, which we were able to get furosemide back on the ambulances. And that was really because we were able to empower paramedics to make a diagnosis. So when I first started out, I got a lot of pushback from some of the higher ups in the EMS community in the US about, well, really the pre-hospital is about getting patients to the hospital as quickly as possible. But what we found was that by using this technology, we could make a diagnosis earlier and we could treat patients earlier. So we found that these patients were going to the hospital and then sitting there for 3 hours without the use of ultrasound before they had any sort of heart failure specific treatment. And so the treatment pathway for heart failure was essentially, if they found bilateral B lines, they went down the heart failure pathway, getting furosemide, nitroglycerin, CPAP. If it was not heart failure, then they would treat however they thought what they would do without ultrasound. And that was because we used a very limited protocol where they only looked for zones. And so the patient could still have heart failure and not be picked up on ultrasound. And so if they clinically thought the patient had heart failure, they could still follow that pathway. If they thought it was COPD or some other cause, then they could follow their like COPD asthma pathway. And so I do think by using this technology, we're really able to shift that paradigm of treatment from the hospital setting to much earlier in the disease course for patients to the pre-hospital setting. And I'm a big proponent of paramedics. I also trained EMTs. They didn't use it in my study, but we trained them as well. And we've trained students, we've trained advanced practitioners like APPs. And so really anyone can, like there are studies coming out where patients are learning how to obtain their own images and interpret them. And so this is something that paramedics definitely should feel empowered to be able to use. And I really think that the kind of the culture is changing in that regards as well.
Francis, if I remember your paper right, it was a reduction in time to treatment from 169 minutes to 21. And so, I mean, that's more than 2 hours sitting in an emergency room waiting to get just something as simple as a diuretic to feel better. And if you're somebody short of breath, that feels like forever. I mean, I think that your study was so compelling that it's hard to argue against following that protocol. It really is. I mean, it's candidly, in my eyes, indefensible.
Yeah. And I think that when I was talking to some of the other medical directors for some of the different agencies in where I live, I think that is something that medical directors want to see, like where's the data that this is actually improving care? And so I think trying to put more data out there that this actually improves treatment that the paramedics are giving for the patient before they get to the hospital is going to change how we treat patients in the pre-hospital setting.
Absolutely. And by the way, talking B-lines, did you see that, or did you listen to that ultrasound gel podcast episode where they were trying to figuring out how the number of B-lines and the B-line score is affecting the admission to the hospital? So I was thinking to myself, maybe one day there's going to be a study where we're thinking of where we're using the B-line counter, for example, of the butterfly, because maybe that correlates with the decision whether the child with a bronchiolitis might need an intensive care unit or not. Because especially in for example, in Vienna, it's also all about resources and who is taking the decision where the patient is being brought to. It's the paramedic out there. You know, I think and it always comes out, it kind of always narrows down to the EFAST. I think one of the biggest misconceptions in POCUS is that POCUS in the pre-hospital field is something for the time critical emergency. For example, the EFAST is always being dragged out as example. If I have a severe polytrauma patient, I don't need ultrasound to be quite frank, because if he has a thorax trauma and he's bleeding and he's in shock, I got to bring him to the surgeon. But for example, these lower prioritized emergencies where no emergency physician or advanced paramedic is being dispatched, you know, is the patient that is, for example, suffering from light dyspnea or from just a light thoracic pain. And the guys who have to deal with that are the paramedics. So I don't want to show them this is the tool that you use in the most critical cases and only in shock and only EFAS and resuscitation. But this is your everyday tool in every patient where you would use a stethoscope, because it's just far more accurate. You know, so
the problem is imagine this, Dr. Tall. Imagine I'm one of the paramedics and I'm coming to you and I got to persuade you to let me get ultrasound. I got to talk you into it. You're the jury. And I come to you and I go, listen, there's this thing called ultrasound. I don't know if you've heard of it, but like we can do a lot of cool stuff with it, right? And we can do ocular nerve sheaths. We can start IVs. We can do EFAST exams. We can do stellate ganglion blocks. We can look at fracture. And I start listing you all the things and your mind's going, I can't even get half these guys to do a 12 lead in the blood sugar. Like, why am I going to give you this thing that does all of these things if I can't get these metrics met, these KPIs met? And so that's why when I think about, and I think this would be an interesting topic. I see we're coming towards the end of it, but like wrong moves when it comes to implementing ultrasound. What are some wrong moves? And I would say one of them, the one that comes to mind, is thinking that you're going to do all of these things. Like Dr. Russell said, we're going to look at lung sliding. I wouldn't say, all right, we're going to start off with the EFAST. I don't think that's where the bang for the buck is. Let's just start off with lungs. All right, let's start off looking at the heart and cardiac arrest and then work those things into it. I think that's a wrong move. And then I think the other wrong move is to say, you know what, we'll buy one, we'll put it on a supervisor truck. If you think you need it, call the supervisor out and then he can take a look. Because that is too many barriers. We used to keep our ultrasound in the helicopter. We used to keep it in a box behind the forward-facing seat in the helicopter. How much use do you think it got to go, I got to get it out of the webbing. I got to get it out of the box. I got to plug it in. I got to set it up. Never mind. We're almost there, right? So once we put it in our actual first in bag, boom, everybody started using it because it was those barriers. So those are my two. I think thinking you can do everything with ultrasound, and then two, thinking that you can buy one and just have one person do them all, or you can put it in a box and don't take it on scene. I don't want it to delay scene time. Just maybe if you have a chance during transport, take a look. So that way we can make a public post saying we have ultrasound now, right? Those are the wrong moves that I think. So I'm curious, what do you think, Dr. Tao, what do you think is a wrong move when implementing this?
I think the wrong move is to put the ultrasound probe into a box. That's why I encourage all my students always, the first thing on the shift is take out the iPad, log in with your data into the app, and then take the probe and put it inside of your jacket, because then you're going to use it, and you're going to use it on a regular basis. We even started a small campaign which is called "No Bag, Just Drag." Hashtag "No Bag, Just Drag" to encourage people to do so. And I think, it all just comes down to using it and start using it. And I just had this thought coming up, which is quite an analogy. 2 years ago, I did my first clamshell thoracotomy course, and I thought to myself, "Oh my God, I've never been a surgeon before. I mean, I did some surgery in my med school and after med school in my training, but how could I ever feel confident enough to open a thorax in the field and perform a clamshell thoracotomy?" And then you undergo the training and you do it on the cadaver, and then you just figure out, okay, I think the surgeons, the trauma surgeons, and the thoracic surgeons, they show me how to do it, and you just train it, and you go through the training. And then we had our first successful thoracotomy in Vienna, performed by an internal medicine doctor and a pulmonologist.
Yeah.
So,
oh yeah.
and I
can
think
totally see
I
that.
think it's exactly the same with ultrasound. You have your aha moments, and the more you trust the people and the more you show them how to use it, it's exactly how you described it, Tyler. Yeah, just start with taking the probe and put it on the chest wall. And in the first 5 patients, you're not going to see anything. And then you're going to have your first patient where you see something. And we all remind ourselves, and we all memorize the moment where we first saw a critical diagnosis in a patient with a heart. I still have in the mind my first aortic syndrome, my first aortic dissection that I recognized, and I thought to myself, am I really seeing this now? Is this the moment? You know, is
Yeah.
this the
Well,
moment? No,
if you would,
I have to call my body.
You probably did want to see it, but
Well,
yeah, it was.
this is how ultrasound has changed the world, right? At least in our training in emergency medicine, the standard of care for thoracics is to miss the diagnosis first time around. Why is that? Because we never looked. And now you do a parasternal law access view on a patient who has weird chest pain, and there is a thoracic aneurysm and dissection. So it changes thought process of, if I can now look and see, I can actually make diagnoses which I would miss because I just never looked. We're out of time. This always feels like we do these and we're just getting warmed up. So thank you all for doing this, and would like each of you to just give a parting thought of success or about doing pre-hospital ultrasound. I feel the pearl of wisdom. And
Peter, can I jump in with one quick comment?
please, you take it and run it out.
Well,
We're great.
just because of I just wanted to ask, like, in your final comments, there was an interesting question about a person from the state of Georgia asking about kind of where their current practice environment is, about just being able to use ultrasound for IV placement. In your parting comments, if you any voice of wisdom or advice for that person to kind of how they could get started, would be greatly appreciated, I think, to our audience. So, Peter, sorry to cut you off. I just wanted to kind of throw that in there into the mix for your considerations. And then, yeah, please take it away.
awesome. I'll
Francis?
round it.
Or Tyler, go, please. Yeah, go jump in.
Yeah, I
Thank
can
you.
round it out. So, obviously there's a ton of questions, and I will give you guys my email, tyler@foamfrat.com. Feel free to hit me up with any questions. I think that this is one of the things in ultrasound or in EMS that is kind of like 12 leads, where at first you kind of debate whether you think paramedics can do it. And then you're like, you can do it, but you just got to send me a copy of it. And I got to make sure you didn't mess it up. And then it's like, you know what? Okay, you can just do it. So I think that's going to be the route that these things turn into. And so I'm excited. I'm happy to help. If you guys have any questions about I didn't invent these processes that I use at LifeLink 3. These are things that people way smarter than me have developed, but I'm happy to talk about them and how we're using them. So thanks for the invite, guys. I appreciate it.
Ben.
Yeah, thank you very much for having me. And Tyler, I would like to get you in contact with me after this discussion, because I would love to invite you to Vienna for our next POCUS course happening in June, August, or November. Just pick one. But I think you're just the perfect paramedic to
I appreciate it, man. I'll be there.
And I think Peter's going to be there too. And I think we need more paramedics who tell our doctors how it's done. So feel yourself warmly invited.
Thank you. I appreciate it.
And
Thank you,
Francis.
Ben. I will also come to Vienna.
Always.
Yeah.
I just want to say, I think paramedics should feel empowered to use this technology. It makes physicians better physicians. It will make paramedics better paramedics. So, and I think when you're starting out, you may not feel confident. You may get pushback from physicians when you're bringing a patient into an emergency department, but that shouldn't deter you from using it. And I think if this is something you're going to be implementing in your system, and I hear from paramedics all the time where they're like, oh, our agency just bought an ultrasound. I think that's great, but I think there have to be some guardrails in place in terms of some sort of quality assurance, as well as a discussion with the medical directors of the hospitals you're going to, so that the physicians are aware that you're doing this. And someone had asked before, like, oh, will physicians really believe what I see? I would tell the paramedics, bring the ultrasound in, show them the B-line, show them your findings. And then they have to believe you, and they can do whatever they want, but that shouldn't deter you from using it.
Those are awesome points. And I'll just add to that last point. I think we've all had that experience where it was, for us, maybe, for instance, frustrating, where we would do an ultrasound and have a finding, and then somebody else would say, well, do something else because I don't believe you. But what it does mean as you're practicing is that you're learning how to make that clinical decision and clinical awareness earlier. And what we're doing is caring for patients. And so it has to be integrated. It has to grow with the system. But just learning that you can take a look and understand what you're doing with the patient in front of you, whether somebody wants to do something else afterwards or not, that's almost immaterial. It's just the confidence that what you're doing is making a difference in someone's life. I know Devinder and John want to close it out, and thank you all so much. And thank you everyone who's been listening to the audience. This has been really fun. Hope it was fun for you.
I'll just go ahead, John, please.
So I would just say most people get in to become paramedics or physicians because they want to help people. That's why we do what we do. We want to advance the health of people and we want to save lives. And I think we all have the desire to be the very best at what we do. And I think in this day and age now with ultrasound around, if you want to be the very best at what you do, you need to learn this skill. And I think you need to be your own advocate. I think you need to get a probe in your hand and practice, practice, practice. But you also need to find people that will help you when you practice, because I can play golf 5 days a week, but if I'm swinging it the wrong way, I'm still going to be as bad at the end of the week I was at the beginning. And what I will tell you is on this panel were people that are all willing to help you. Reach out to them. There are people all across the country that want to see you be successful. There's no shortage of videos or people or opportunities to learn. And so look in the mirror, become the best you can be, and pick up a probe and scan.
That's great.
Thank you, everybody.
Thank you all.
Good night.